And Alistair, if you're happy to share your screen, hopefully everything works all right.
Yeah.
You can take it away.
Okay, just share my screen now. So, oh, giving the game away there. Okay. Slideshow. Beginning. Right, can we all see that okay?
Yes.
Right, excellent. Okay, well, good afternoon, everyone. I hope you've had a really productive and excellent workshop so far. I'm a little gutted that I couldn't join you in person or indeed earlier today. Teaching duties unfortunately got in the way. I first came across this modelling framework in 2017, and I should say, as you can see from the slides, I'm not a disease epidemiologist, I'm not a biostatistician, I am a human geographer at heart, and so having a workshop like this would have been wonderful 5 years ago. So yeah, I hope you're having a really good experience so far. So today I'm just going to do a quick talk about pertussis in England and Wales and my modelling of that. This was part of my PhD research looking at endemic persistence and this whole concept of the endemic threshold, or as we also call it, the critical community size. And really, as a geographer, I wanted to explore how the endemic persistence of disease in regional populations within England and Wales maybe diverge, given that each region has its own sort of spatial structure shaped by economic and historical processes. So looking at the effects of vaccination, demographic stochasticity, geographical connectivity and spatial structure, and how these influence endemic threshold and the persistence of pertussis in this case. So that's just a quick overview. I think most of us are probably aware of endemic thresholds and critical community size, the minimum population size required to ensure that an infection will remain endemic without the introduction from external sources and places. And key to that in the work of my respondent is, of course, demographic stochasticity and disease persistence being dependent on transmission between geographical units. So that's just a bit of background there. So the region I was looking at that I'm going to focus on here is South Wales. Now, South Wales is an interesting region in that you have this densely populated, peri-urbanized valleys in the east of the region. And then, as you can see, the rest of the region, you have quite large areas where the population is highly dispersed, quite rural, and transport, network links, connectivity is quite limited. Much of the population is concentrated within Swansea, Cardiff and the valleys. And this all links to the economic history of the region with coal and iron extraction and so on. So the study period I looked at, basically the 1940 to 1970. The reason I looked at this period is because it gives me, with the historical data that I had, about 15 years either side of the introduction of vaccination. So to compare the pre-vaccine and vaccine era dynamics of pertussis. Within that, you do have the baby boom, which of course, as an event in terms of the intrinsic growth in birth rates and demographic, it's quite an important event. And so the pertussis vaccine was introduced in 1957. That's when it was introduced nationwide and fully rolled out. So that's a bit about the period there. The data sources. So it wasn't just looking at South Wales, I looked at Lancashire as well. So together in those two regions, you have about 200 local districts. So nearly just over 1,500 weekly reports, which I digitized by hand, and goodness, that was quite a process. That's weekly data. And then with demographic data in terms of birth rates and death rates and so on, that's at an annual level. That's annual district level data. And then you have the Medical Officer of Health reports. These are also annual reports at the district level. And they, at least half of them, at least half of the districts, they have quite complete records on the number of children under the age of 5 vaccinated for childhood infections like pertussis at school. Unfortunately, it is quite sketchy data. The report's quite idiosyncratic. So there was quite a bit of interpolation needed and use of estimates to try and figure out what was the best sort of estimate of vaccination coverage to include within the modelling. And so here's just a bit about some of the patterns that you see with whooping cough in South Wales. So this is just looking at urban districts. As you can see, when vaccination is introduced, there's quite a difference in terms of the monthly incidence, the number of notifications reported of the disease. And here it's just looking at endemicity. So really it's the proportion of weeks in which cases were reported, pertussis cases were reported at the district level. And what you see around 55, 58, around that sort of time, the endemicity falls quite substantially, coinciding with the introduction of vaccination. So here, just part as a geographer, when I use the hhh4 modelling framework, that was part of a range of tools that I was using for this project. So here was just looking in this slide, the spatial synchrony in sort of regional dynamics and at the local level as well. And we could sort of see that the dynamics in these districts are concentrated around what's happening, or more strongly correlated with the regional pattern that's centered in the valleys. And as you sort of spread outwards, disease activity is less correlated with the regional pattern. And so then we get to the modeling. So I'm not going to speak too much about this. We all know now what this modeling framework is all about. So what I'm going to show here, so using the component outputs from I think for this one would be the baseline model. And so the baseline model for me, I had an endemic, the autoaggressive and spatial temporal components, but this sort of assumes, in this model, assumes a continuous process of disease spread rather than incorporate a more, more complex sort of network connectivity that would be expected. That was something I did in my thesis, but for this purpose of this talk, just showing here, mapping out the neighborhood effects, the neighborhood components. And what we see is that in the earlier parts of this study period, the neighborhood effect is quite strong. And then as we come to 58, that key point, the neighborhood effect is reduced. And so the neighborhood transmission seems to be more concentrated and limited indeed to where the majority of the population is centered in South Wales, in this region, in Glamorgan, between Swansea and Cardiff and the valleys, where you have a high number of birth rates, where people are more densely populated, and so on.
We've got 5 minutes left, Alistair.
Okay. So with all the sort of component data that was produced from the models, I tried to think of a way of, because I have so many districts, how I could present this data in a way which would be quite easy on the eye, being a geographer, something that'd be quite visual, quite neat, try and tease out some of these spatial patterns. And of course, with endemic persistence, population size, community size is so important. So using the components produced from the models, I use a Pca analysis, or sort of reduce the dimensionality and see what patterns I could find. And what you see here, Cardiff and Swansea, and that little yellow dot at the bottom, I believe, is Newport. These are the most populated districts in South Wales. These are basically where disease is most endemic, and this is also where the birth rates are highest, and so on. So you hear this sort of the center of epidemic activity, right? These are where the epidemics are born, and they sort of fan out from these urban centers to the rest of the wider region. But what you also see is you have these groupings. So the smallest communities, the red dots, they tend to be further away from the endemic center, and so on. So this was a first order model. This is just assuming that disease spread is a purely contiguous process, essentially, just assuming that infection flows from neighboring district to neighboring district, sharing borders. As here was a more complex model where I included immunization and vaccination coverage, as well as the power law component and distance decay. So more complex spatial network was included. And then also random effects, because of course, can't just look at a regional metapopulation like South Wales in isolation. There are going to be some edge effects given its connectivity with England and other parts of Wales. But nevertheless, you see a fairly similar pattern here. Distance playing an even greater role in explaining the sort of small community size. These communities is where disease is almost non-existent, right? They just fades out with the introduction of vaccination. And here is just what I did really with pertussis in Lancashire, following a similar sort of pattern. And what's noticeable when you look at neighbourhood effects in the earlier time windows of the study period, the districts around Manchester and Liverpool, this is where the neighbourhood effects are strongest. Of course, places, if you've been to Greater Manchester and Liverpool, there is so much of a spatial import infection into these areas, these suburban areas. And then beyond the confines of sort of Greater Manchester and Merseyside, the neighbourhood effects are reduced. And so these are just some of the conclusions I came to. So vaccination synchronizes region-wide the pertussis epidemics, and that significantly increases the endemic threshold population. That's why we get this reduction in endemicity in the later windows. And by doing that, of course, vaccination increases the fade-out duration, reduces rates of disease reduction, etc., and that diminishes that neighbourhood effect and that spatial import. And of course, demographic statisticity is a crucial driver of disease persistence. We all know that. And if we have ineffective immunisation, it result in rescue effects on a local scale. And one of the things I like about the modelling framework is those overall district plots where you can actually pick out each district and break down the epidemic pattern in each. Because in a regional population like Lancashire, for instance, Liverpool and Manchester, despite being 30 miles apart, have very different epidemic patterns. And, as shown in the previous slide, you also see these districts around them. They're very much dependent on that spatial flow. So having those plots, the overall district plots, are really useful for me and studying what I study. So that's it really, that's all from me. Thank you for listening to me, and I look forward to hearing everybody else's talks.
Thanks very much for that, Alistair. I think we've got time, probably a minute for a question, if anyone has any. Sorry. Any questions in the room or on the chat? Okay, well, if nobody has any questions, then we will thank Alistair again. Thanks very much for that.
No problem. Thank you.
We'll move on to Alexi next, I think.
Hi, give me just a second. Can everyone see the slides? Is that working? Everyone can hear me? Yeah, we're good? Fantastic. Yep. Sorry. All right, very good. Hi, everyone. My name is Alexis Robert. I'm a research fellow at the London School of Hygiene and Tropical Medicine, and I'm going to talk about measles in France, which is a nice way to summarize this outrageously long title here. And it's a project I worked on during my PhD, and I worked on this with Sebastian Funk and Adam Kucharski. So my PhD was mainly on modeling the spread of measles and the risk of measles outbreaks in near-elimination settings. And in this project specifically, I focused on deciphering the impact of local vaccine coverage and past outbreaks on measles susceptibility. So when I mention near-elimination settings, I think I have to clarify what elimination means. So as defined by WHO, measles elimination refers to the absence of endemic measles transmission in a defined geographical area. So that can be a country, it can be a set of countries, so a region, for more than a year in the presence of a well-performing surveillance system. And it can be verified after 36 months of interrupted endemic virus measles transmission, meaning after, more or less 3 years with very low number of cases. However, the elimination status can be a bit unstable. That's an example with the UK. So you have, if you focus on these 3 columns here, you have the number of measles cases per year and the WHO status corresponding to that. So for the first few years, between 2010 and 2013, we have more than a few hundred, up to a few thousand cases, and that's what we call an endemic transmission. Then for 2 years, we have interrupted endemic transmission, so less than 100 cases. And from that, measles was eliminated in the UK, but actually straight after that, we have a few hundred cases and then 1,000 cases, and basically the UK lost its elimination status. So it's not great that 2 years after declaring measles eliminated, well, actually almost immediately, we see this like fairly large outbreak for measles. And that's a pattern that we saw in the UK, but that we also saw in other countries such as Czech Republic or Brazil as well. And so that led us to 2 research questions, kind of. One, is it actually less likely to see an outbreak after 3 years, a measles outbreak for 3 years without transmission? And 2, basically, should we look into other indicators and potentially vaccine coverage to try and anticipate the risks of outbreaks? To do that, we looked at measles case counts from France. So we had local case counts between 2009 and 2019, so per French département, which I'll show you later what that corresponds to, but there are 95 of them in France, metropolitan France. And France is a good example because we have kind of the pattern I was mentioning before with years with pretty large outbreaks. Measles, why that has nothing to do with COVID numbers, but for measles, that's gigantic in France at least. And here we have like a few years with barely any case. So we thought it'd be interesting to try and see what's associated with those spikes in cases. And because we had daily case counts and because we had local case counts, we decided to use the endemic epidemic model, which had mostly been applied to aggregated data. So where the average number of cases at T depends on the previous iteration, and we didn't think that would be adapted to measles, where the serial interval is about 10, 11 days. So we computed a composite serial interval and used basically the same approach as hhh4 add-on. So I'm referring to a composite serial interval because we wanted to take into account the fact there could be different scenarios of transmission. So if you have, if you have a case at, say, time t, you want to take into account the risks of kind of like direct transmissions, number of cases that they will lead to, say, 10 days later. So that's a direct transmission, no missing cases in the middle, no underreporting problem. We also want to take into account that maybe you'll see a case at a certain time point, you won't see the case that they may infect, but you'll see a case a generation later, so you would have one missing link here. So the serial interval with that would be the convolution of the serial interval with itself. And we also want to take into account the idea maybe you could have cases stemming from the same unreported infector. So maybe this person should be captured by the endemic component, and these two should be in the autoregressive component. But if you don't have this case here, the model might consider that having 2 cases imported at the same time is a bit unlikely. And so we want to take that into account in the serial interval, in the lag distribution. So that's what the serial interval looks like. So here you have, if you see a case at a certain time point, you have some risk that you see another case immediately following that case. Then you have some risk that you have other cases about 10 days later, 11 days later. And then that's if you have a missing generation. And then we integrated different covariates, mainly 2 of interest, and then some control covariates. First, we had the value of vaccine uptake, local vaccine uptake, that we averaged over the past 3 years. So for example, that's the latest value for 2018. So that's the average vaccine uptake, local vaccine uptake in 2016, 17, and 18. And we used the first dose vaccine coverage because we had better data. Basically, it was better reported, especially for around 2007, 2008. As you can see on this map, so that's what département look like. As you can see on this map, we have some variation in coverage in southeast. It can be below 80%. whereas in North and West, it's more likely to be over 90%. We also wanted to take into account potentially the immunity due to previous outbreak, the impact of previous incidents. So we took the total number of cases in the region over the past 3 years. So taking the past 3 years kind of to mimic the elimination status, we converted that to number of cases per million, and we grouped it in 3 categories. So if you have less than 10 cases per million, then we consider you had very few cases in recent years. So only maybe a couple of importations, but no local transmission. If you had less than 45 cases per million, you had probably some transmission, some local transmission, but no major outbreak. And over 45, sorry, it's for regions that had more important outbreaks. And we control for different things, for example, seasonality. That's the number of cases reported per month throughout our data set. So you see that seasonality seems to have a slight impact on the number of cases here that we have every month. And also we consider the number of inhabitants per region because there are big discrepancies here in France between regions that have very few inhabitants and versus very populated areas. Now we run our model and we look into the impact of each covariate. Here, that's on the autoregressive components. That's the risk of transmission within the region. If you have a case in the region, how many cases do you expect in future time steps? We see that so positive values mean that we expect more cases. So if we have more unvaccinated, the higher proportion of unvaccinated people, we observe more cases, more risks of secondary transmission, which is positive, which is what we expected, but it's always good to see. So the proportion of children vaccinated seem to have a positive association with the number of cases. And however, this is interesting. So the value of reference is region that had almost no incidents in the past 3 years. And we see that region that had larger outbreaks in the past 3 years have a lower level of transmission expected, which can be explained by natural immunity. Basically, people who have been infected during these outbreaks cannot be infected anymore. It's interesting because if we connect that to the elimination status, we would expect that if you haven't seen any outbreaks in recent years, you should be less likely to have an outbreak. And then we can basically look into the risk per region in 2019 for the autoregressive component, and that's what it looks like. So we have slight differences between regions. In the Southwest, we have higher risks of secondary transmission, in the North as well. This is average across the year, but of course with seasonality, this will increase and decrease throughout the year, but everywhere in the same way. And then we can look at the other 2 components, so the neighborhood component and endemic component, that have fairly similar behavior. Once again, if you have more people unvaccinated, you're more likely to see importations from other regions, which is expected. But with incidence, we observe the opposite phenomenon. If you've had many cases in recent years, then you expect more importations. I suspect that this comes from the fact that the model considers that regions that have seen many cases, well, more cases in recent years, are more highly connected than it would expect them to be. But in both cases, the most important covariate was population. So if you're in a region with many inhabitants, you tend to attract people a bit more, which again is expected. And that's the maps you get. As you see, the regions that have the highest value for the predictors are the ones that have major cities. So like in Marseille or Nyon, or we have Toulouse as well. So yeah, that was the main predictor, but it was reassuring as well to see that vaccination was always associated with lower risks of importation. Once we have these parameter sets, we could simulate the impact of, for example, of changes in vaccine uptake. So we took our parameter set and we just generated 1 year of outbreaks, and we generated many simulations. And we looked across the simulation set in each region, what was the proportion of simulation where we saw at least 1 case, at least 10 cases, and at least 50 cases. So if we use the same values of coverage in 2018, the right values of coverage in 2018, the ones were reported, we see that not every region is always exposed to measles cases. There are some regions that usually don't see any case. For example, here, they see a case in less than 50% of the simulations. And also, there's a differential risk of outbreak of larger outbreaks in the country. But there's no region that is always affected by a larger outbreak, by local transmission, with at least 50 cases here. However, when we decrease the vaccine coverage by 3%, the average vaccine uptake, we see that it has quite a drastic impact on the risk of transmission. Almost all regions are always exposed to measles cases, and we see active transmission in a majority of simulation in quite a few regions here. And if my memory serves me well, on average, that results in a 5 times increase in the number of cases per simulation on average. However, when we decrease coverage by 3%, when we increase coverage by 3%, sorry, I got that the wrong way around, we really reduce the risk of local transmission, as you see here. And I think that's a decrease that's like 3 times fewer cases here in this simulation set. So yeah, it was interesting to see that changes in vaccine coverage had such a large impact on the number of cases expected in the simulations. So that's a quick summary of what we've done. Sorry, Lloyd, yeah. I don't know if you're saying something. Oh. So our conclusions from that would be that the indicators used to define the elimination status were not really associated with a lower risk of transmission at a local scale as well. If anything, it was the opposite. If you hadn't seen any case in about 3 years, you were more likely to see a local transmission. However, we believe that this highlights the importance of high quality local measures of vaccine uptake to anticipate risk of outbreaks. Here we've used first dose coverage, but probably second dose coverage would be quite important as well. If we had the data to do that, we could probably implement an age stratified model and see the impact of vaccine coverage for each age group. That would be quite interesting, but we couldn't do that here. And finally, given the current disruptions in routine immunization campaigns and drops in vaccine coverage that have been reported in England, for example, we believe this may lead to important changes in transmission levels and potentially large increase in transmission levels, especially that in Europe, at least, there hasn't been a lot of measles transmission in recent years, so natural immunity will not be too high either. So that's, we'll say, a little bit concerning. Yeah, this paper was recently published, so please feel free to have a look and tell us if you have any feedback on it. That's always great to hear. I'd like to thank Seb and Adam who worked with me on that, and the people at the CDC with whom we worked to get the data and then to analyze the data a little bit. So yeah, thank you very much. If there are any questions, if there's any time for question, be happy to take any.
Thanks very much for that, Alexi. I think we have time probably for one question, maybe, if anyone has one. Anyone in the audience or anyone online? Okay, we have a question from the audience.
Alexi says that the tablets show the way you define the elimination for measles under the condition that it's being monitored by a well-performing, I don't remember the exact wording, by well-performing surveillance system. How do they define, or do they give any definition of what is for the WHO well-performing surveillance system?
So you probably didn't hear that, people online.
Yeah, sorry. Can you repeat?
I'll relay the question. So Claudio's question was that you had a quote, I think, from the WHO about a definition of kind of elimination, but based on a well-performing surveillance system. And Claudio's question was, how exactly do they define a well-performing surveillance system?
That is a great question. I would say, at least as far as I know, as far as I've seen, there's no clear-cut definition of what is a well-performing surveillance system here. I think I would say at the moment they assume that if you're in a position to be like near elimination, if you have very few cases, it's quite likely you have a well-performing surveillance system. Therefore, I don't think there's a lot of debate around that. But yeah, that I didn't really find a clear definition of what would be a well-performing surveillance system. I think it's to say that, like, basically it's to avoid having a situation where basically people are saying, well, we don't have any measles transmission, but it's just that they don't see any because they don't have the system to report these cases. So I think, yeah, most countries have what they call a well-performing surveillance system. That's the way I would phrase it. I'm sorry, it's not very clear, but it's not very clear to me either. If that can help.
Thanks very much. Any more questions from anyone? Okay, well, I think with that, then we will move on to Emily next, who's hopefully online. So Emily, if you are there, you will be able to share your slides and then you can take it away.
Is that clear?
Yep.
Yep. So yeah, hi everyone. My name is Emily Nightingale. I'm a research fellow at hhh4, and I'm going to talk a bit about some work we did quite a few years ago now, looking at short-term prediction of visceral leishmaniasis for an elimination program in India. So to start with a bit of background, VL is a vector-borne disease. It's considered a neglected tropical disease and is targeted for elimination across the Indian subcontinent, so India, Nepal and Bangladesh. And in this case, similar to what we've just discussed, elimination is defined as less than one case per 10,000 population at the sub-district level, which is also referred to the block level. So that's the sort of WHO official definition for this elimination program. Now, because of this this program, the incidence of VR has reduced quite substantially over the area in the past few decades, and now only really is sort of focused in this northeastern corner of India, these 4 states, and in particular, Bihar state is the primarily affected area, and over 90% of the incidence in India comes from Bihar state. So even though they've made all this progress over recent years, there's still a substantial proportion of sub-districts in this area that are not meeting this target. So there's a motivation to monitor incidents at this level and better understand which areas are at risk of not meeting the elimination targets. So incidence of VL is a notifiable disease in India, and all cases are reported to an online surveillance database called CAMIS. So these are the data that we used for this analysis, and you can see in the top right here, this is aggregated monthly over the entire area, and there's quite a clear seasonality to the pattern with an overall decreasing trend. However, the map below shows that this overall quite clear pattern is quite variable on a spatial level between blocks, and although the majority of the state is in fact reporting very, very low incidence, which is below the target, there's several blocks which are still much higher. So we set out with this project to see if we could characterize these patterns over space and time in a model to provide a way to monitor incidents on a monthly basis based on the data that's currently available. And we used data from 2013 to 2018 for this from the National Surveillance System. So, as I said, the sort of primary aim for this work was to produce short-term forecasts of these diagnosed cases at the block level as a way of monitoring progress towards elimination in this area of the country, and potentially flag up blocks which were diverging from the overall trends in the region. And in particular, we want to do this, develop this model from the perspective of outer sample predictive power rather than fit to training data. So we sort of developed the model with that in mind. And then for the final model, we wanted to evaluate how much that predictive power is lost if we look at a longer time horizon ahead from the available data. So surprise, surprise, we used the hhh4 framework for this. And our model was on, as I said, on the block level and per month. So we also then were made use of Johannes's hhh4 add-on package for fitting lags further back in time, or like dependence on lags further back in time. So we looked at up to 4 months prior to the current time point. So I suppose in some examples for some disease, it might be quite clear what's a sort of sensible structure to the model from a sort of epidemiological perspective. But a lot of the elements of VL transmission are not very well quantified, and in particular, like how that would sort of present on this like aggregated level. So we sort of went into this trying to have a bit of a sort of transmission agnostic approach, and we ended up developing the model with a sort of semi-systematic selection approach by adding complexity in turn to the endemic, the autoregressive, and the neighborhood components, and then incorporating that which yielded the best improvement in the ranked probability of score of one step ahead predictions. Sorry, I haven't talked this much in a few days. Excuse me. So where was I? Yeah, so in doing this, keeping that sort of one step ahead predictive power in mind, we ended up with a final model which incorporated incidence from 4 months prior to the current time point, and then also the neighborhood component between direct neighboring blocks, and then seasonality in both of those components. So in particular, this sort of forward section approach highlighted that adding that information from neighboring blocks was quite important in improving predictive power relative to only looking at autoregression over time. And we also found from the final model that predicting 3 or 4 months ahead was not substantially poorer than only 1 month ahead for most of blocks. Sorry, I should have thought ahead and brought a glass of water. So as you can see here, this is the block averaged rank probability score from 1 month ahead versus 3 and 4 months over the 24-month time period that we looked at for testing. And you can see that, yeah, for the majority of blocks, it's very similar for the 2 time horizons. However, you can see from the sort of scale on the axes that there was quite substantial variation in the strength of the prediction between different blocks. And the longer time horizon of 4 months does have a detrimental impact, in particular for those which were already quite difficult to predict, even just looking at 1 month ahead. So these blocks which were already difficult to predict 1 month ahead tended to be those which had more sporadic incidents, so sudden spikes of incidents, for example, like this block, which is illustrated in the top 3 panels. So here we have predicted quantiles 1, 3, and 4 months ahead of the data which we trained the model on. for example, block Pca, which had quite a large spike of incidence at the end of the 5th year, I think. So I don't know if you can see these sort of these crosses are where the observed data did not fall within the predicted quantile. So this sort of sharp spike in incidence isn't anticipated by prior incidents in the block or in the neighboring blocks. And then missing this this spike gets worse sort of the further ahead you're trying to predict, which results in poorer prediction scores. So this was something that was problematic in a sort of subset of the blocks that we looked at. But overall, these sort of forecasted prediction quantiles were conservative, so they had higher coverage on average than the nominal level. So the widest one we looked at was 80% interval, which overall the blocks captured over 90% of the observed values. So essentially the model's predicting more variance in incidence than was observed, which is likely because of the combination of these occasional sharp spikes in incidence alongside many blocks which have very low or often zero incidence, which is which we found was quite sort of difficult to capture in one model structure. So just some the overall conclusions that we drew from this were that firstly there is a correlation in VL incidence between neighbouring blocks, which is important to draw on to inform forecasts to be made ahead of time for the elimination programme. And we were able to use this information to obtain predictions of quite reasonable accuracy up to 3 months ahead of the training data, which is an important time horizon because it can take a couple of months for incoming diagnosis reports to be processed and available in the surveillance system. So forecasts ahead of time would mean that we can make forecasts genuinely ahead of time and not just ahead of the data that are available. So that can be acted on by the programme. Oh, I am sorry. So these kind of forecasts could be used to monitor progress of this region towards incidence targets. And oh God. I'm going to get there eventually. I don't know if no one will do, but I do have COVID currently. Surprise, surprise. So yeah, we could use this to monitor which blocks might be deviating from overall trends. For example, similar to what Claudia described earlier, flagging up those that were substantially different to the forecasts, and works sort of ongoing to try and integrate this into practice. But in terms of some limitations, because BHAR is in a position of being very close to elimination, there's quite contrasting patterns of incidence between different blocks, which we found made it quite difficult to settle on one model structure to which was like the most appropriate for everywhere, to like account for all different areas at once. And this is likely to become an increasing issue as elimination is further approached. So in particular, the strength of the model was worse in predicting in areas which had that sporadic kind of incidence. Oops, sorry. And secondly, transmission actually occurs on a smaller scale than the block level, and interventions are implemented on a smaller scale. And we're at the same time with this this issue of sporadic incidence, we might be sort of reaching the limit of this kind of area level modelling for producing forecasts, and in future might need to draw more on more detail of the actual transmission process on a local level to explain the patterns that we observe. And then finally, there's a sort of an increasing question over the representativeness of the surveillance data. These forecasts are of observed diagnoses, not actual incidents. So could give a biased perspective about where actual highest and lowest risk areas are, depending on how surveillance, the sort of strength of surveillance over the whole area, and in particular, whether the surveillance is focused on areas considered to be at risk, based on sort of historic trends. And then especially also over the last few years, the disruption in case detection as a result of the pandemic will probably have had a big impact on case numbers that were observed. So going forward, attempts to sort of model and forecast using the surveillance data will need to take into account that kind of potential disruption and bias in the counts from the last few years. Okay, we've got I just wanted to thank the co-authors and collaborators on this project. Yeah, and this is the paper linked here. Thank you.
Thanks very much for soldiering through that, Emily. I think in the interest of time, we will ask people to put questions in the chat if they have any, and move on to the next presentation. So if you are there, Cece, if you would be able to share your screen, that would be great.
Right. Can you guys see my screen?
Yep.
All right. Well, thank you all for the opportunity to talk about my work, and really motivated by the epidemic endemic modeling framework. And then probably you can tell by my accent, I'm actually calling in from Houston, Texas, from United States. And it's great to see all these new developments on the modeling framework. This is work really, we started quite a few years ago. And there's a paper we published back in 2018. And I have to say that there have been a lot of new things with the package, and I recently got the chance to look at it. The menu is over 300 pages now. It's really impressive. So what I want to talk a little bit is about the stratified space and time infectious disease modeling. And let's get to it. Oops, why is not, okay. All right, first I want to talk a little bit of the motivating example. In this case, we used a pretty old data now. It's from hand-foot-mouth disease, from surveillance data from China. So this is hand-foot-mouth disease is a viral infection, mostly occur to children. So don't get this confused with the hoof-mouth disease. So this is again, similar to many of the surveillance data that have been talked about, is we don't have the individual level information, and most of the cases are aggregated by space, by time. But one unique aspect that really motivated us to do this work is we are also interested in the potential transmission between this group. And the idea is if being able to get some estimates of the transmissibility between different groups using aggregated surveillance data will really kind of aid understanding the disease etiology and intervention approach. So here what I'm showing is time series plots, and this is the weekly reported case number, but stratified by these 6 different groups, by gender and by age group. So there are a lot of similarities between these sort of infection pattern over time between different stratum, but there are also some unique patterns that are not quite obvious, which hopefully we can use the modeling approach to help us identify. So the main goal is understanding the space and time dynamics of disease spread, but also we're adding to this part is the transmission between different subgroups and also in space and time. We also want to incorporate various meteorological variables collected over time. This is from weather stations, so we have to do some modeling there to get the point level data to area level summary. And then also we wanted to combine with the surveillance data collected over time and space as well. So I'm going to go just to kind of the high level description of the modeling framework for the stratified sort of model we propose, but I'll defer the details to the paper. So first of all is we kind of extended from this basic or classic chain binomial model to allowing transmission from different transmission sources. Then you'll see a lot of similarities with how these transmission sources being decomposed into epidemic and endemic components. And the cases that we're looking at are all the outcome variables. Y is now having an additional subscript, which is the stratum J. So we have time T, area I, and also stratum J. And now the infections can really occur, once you add this dimension of the stratum, the infection can occur from these different sources, right? There is the infective in area I, but also from a different stratum J prime, or infection can occur from the neighboring areas, but also by different stratum. And then we still have the environmental reservoir. So you can tell that quickly the parameters in this model are getting really complicated. So we still use the multiple forces of infection and going from a pretty simple Poisson approximation to the binomial model. What I want to point it out is now the total infections are still following these general patterns of the autoregressive term, neighboring term, and endemic component. However, because now we have this additional dimension to indicate the stratum, so when we are summing up over different partitions, the autoregressive term or a neighborhood component becoming a little bit more complicated. So again, we have this total infection risk coming from these three different sources. And we wanted to build into this model of the particular disease transmission. So depending on if we think the disease, infectious disease is transmitted by density dependent or by frequency dependent, then there are different forms that we can take by how we model this the risk coming from autoregressive term or neighborhood term. There are a lot of derivations, and so I'm going to defer you to the supplementary materials if you wanted to look at the details. So now application to this hand-foot-mouth disease surveillance data. So as I mentioned, that this particular disease is mostly occurring in young children. So we actually have an indicator variable here to show if school is in session or not. And then we have these number of meteorological variables, mostly focusing on temperature, precipitation, relative humidity, and wind speed. And these are the meteorological variables that have been shown in previous study to potentially related to this particular virus causing the infection. And we also have to do some kind of work on modeling the point level weather station data to this area level summary. And then we have to pay attention to how we want to model the association between these environmental factors like temperature to the infection. And it turns out that we have to use a change point model to model this relationship as, again, temperature. In most of the virus, there is a more suitable temperature for the virus to be most infective. So we have to be able to model that. And then we have also incorporated these covariates at a 1-week lag based on the previous epidemiology studies of hand-foot-mouth disease. So now we can fit this model, and because of the complication of this model, we have to actually, I forgot to mention that this model we actually implemented using the Bayesian framework and in MCMC. And if you are interested, the paper in the supplementary materials actually give you some example code, and that this model can be implemented using Winbucks or can be implemented in STAN. So Recall that this is the mean risk functions that we have for the infection. And now we can still decompose this into the AR component, neighboring component. This is really by summing over all the stratum. And to quantify the contribution from different components over time, that we can define this mu term that's called the components. So by comparing different proportions from the different components, now we can kind of evaluate the contribution of infection coming from different sources. So this is in the same way as the general hhh4 model. So for this particular surveillance data set that we found is really the vast majority of the infection is contributed by the AR component in the non-winter seasons. And during the winter seasons, it's mostly the endemic component contribution. And really, we see the novelty of what the extension of the stratified model is that we're interested in the between stratum transmission. So in this case, we're giving a you can extract this parameter from the extended model that to look at the transmission between different groups. So what you're seeing over here is again showing the this kind of off diagonal part. The diagonal part is mostly the transmissions within the same stratum. And so for hand-foot-mouth disease, it's still mostly occurring in the same age and gender stratum, and followed by the same age, but the opposite gender. But you can still see that depending on which stratum you're looking at, the transmission is slightly different. So I think this is really the in the sense that new information that from using the stratified modeling framework that we are able to make inference about. Now, we're also able to make the seasonality by different stratum, and this is just showing the seasonality component. And what's interesting here is there are slightly difference depending on which stratum you're looking at. So I think this is really warrants some additional information or research to understand why the contribution from the endemic component is having different impact on these different age groups. And then finally, now if we're looking at a particular area, we can look at the different contributions to the infection in that particular area. And then here we just selected 4. Again, generally the model fit is really great. And also showing that variation of the contribution from different components, and they're quite different. And in this case, we're really seeing most of the infections is within area. So you see that some of the neighboring components are not really making that big of contribution. However, there's still variation in regarding that aspect, depending on which area you're looking at. So finally, I would just summarize that this is really the work has been motivated by the hhh4 model framework. We kind of extended it using different implementation approach or using the Bayesian approach so that it allows us to look at the stratum or trying to get a little bit more understanding of the transmission mechanism using the aggregated surveillance data. There's a lot of work that can be done. We have already kind of mentioned in the paper that there's different transmission mode depending on frequency or density dependent. I think this is really important depending on which particular infectious disease you're looking at. Trying to build into that infection mechanism in this surveillance modeling framework, I think is very important. And also, I think that what really gets me motivated and excited about this hhh4 modeling framework is its flexibility, so that we are using a pretty simple approach to look at how do we model the AR component, but we can use, or I should say simple, a parametric approach to look at the autoregressive component. But there are other ways that we can construct these infections coming from different sources. So I'll stop right here and see if you have any questions.
Thanks very much for that, Cece. Does anyone have any questions either in the room or online? You have a question, Seb?
Yeah. So you said you did this in bugs and WinBugs and Stan, and did you compare that to? I mean, I guess it's a different model, but is that much slower than using hhh4?
At the time we were working on this, I don't think hhh4 is able to implement this particular model. So we didn't compare with hh4. I'm not sure if you have the capacity of doing it now. Yeah, but because I think the reason of this is that if you look at over here, there's the summations between over this term, and I'm not sure if that is a hhh4 model is able to implement it now. Perhaps it is. Yeah, so that's why we went to the Bayesian framework, and also. I think the tricky part is now we have this transmission between different, it's basically these JJ terms. And this additional, so if you think about, I have six groups, right? So the transmission between different stratum is going to be a 6 by 6 matrix. So you have to model all this in the sense the entries in the matrix. So you have to really find a way to simplify, otherwise I don't think it can be identified. And in the Bayesian framework, what we did was to put in a sense, informative priors so that this can help with identification of all these, transmission parameters.
Thanks very much for answering that, Cici. So there are a couple of questions from Sam in the chat. He was asking whether you have example code of the model in use or linked. Seb's just answered that question, so apparently there is a link. I think you said there was one, Cici. And Sam's other question was, did you compare the simplified version of the model that you used to the hhh4 model? I think you answered that as well, though, because I think you said that you didn't try the models in hhh4. But if you, yeah.
No, you're right. Yeah, so the code there, it's not exactly the same code, but I think we simplified into a 2-stratum model in the and that is in the supplementary materials of the JISC paper. And I think Stan is going to be faster compared to bugs. But I think really the key was, if you're going to have more stratum, you have to pay attention to how you specify those priors to make them identifiable. And regarding comparison, I think you can run the hhh4 model in the subgroups, so you can find all these neighborhood components by different stratum, but I don't think you're able to really estimate between the stratum, the JJ prime term, that transmission from these different stratum. I would really love to see if it's possible to do that in hh4, because that's going to be so much faster than running MCMC, and it'll be really great to do a comparison.
Great. Thanks very much, Cici, again. I think now we're going to have a discussion looking at